Good evening, Assalamu alaikum and Namaskar, dear veterinarians and enthusiastic vet students and advanced veterinary farmers. Please welcome to our 29th online discussion organized by Adar Health Bangladesh. Today our discussion topic is lumpy skin disease. You know that lumpy skin disease is an important epidemic viral disease causing significant economic losses to dairy and beef cattle producers in Bangladesh. The disease causes severe skin lesions, loss of appetite, and weight loss, decreased milk production, and also some reproductive issues. Currently, there is an ongoing interest on this topic, especially between among the veterinarians inside the country, because there is no specific well-known treatment strategies, and also sometimes a number of reports has been known be, due to the vaccination problems, and the vaccines is not currently available. It's known from many sources, so it's there's a kind lots of discussions needed on this topic. So tonight we are honored to have Professor Dr. Abdul Samad sir as a key speaker to discuss this topic. Dr. Samad sir is a renowned veterinarian in India for 37 years with major expertise in herd health management. He is the former dean of Mumbai Veterinary College. Professor Abdul Samad is currently a member of Indian National Advisory Commission on milk production and farmers' issues established by the Indian Veterinary Association. He is also a member of Research Advisory Council of the National Innovation Foundation under Government of India. We are also delighted to have some experts from Bangladesh as our main discussions. I would like to introduce Professor Dr. Ahsanul Haq sir. Professor Dr. Ahsanul Haq sir is an epidemiologist from Department of Veterinary Medicine and Surgery, Chattogram Veterinary and Animal Sciences University, and he is also running and he is the coordinator of On Health Poultry Hub Bangladesh. Then Dr. In Farad Hossain sir, he is the ex-director of Livestock Research Institute, Department of Livestock Services, and he is also the managing director of Chattogram Veterinary Research and Training Institute, Chattogram. And then Dr. Faisal Talukdar sir, he is Upazila Livestock Officer, and he is also in the epidemiology units of Department of Livestock Services. And then Dr. MD Redion Pasha, he is working as an assistant professor in the Department of Physiology, Pharmacology, Biochemistry, and Pharmacology, and he is also a practicing veterinarian. And then I introduce myself. I am Dr. 𝐓𝐫𝑘𝑀. I am a PhD fellow in Adar Health Bangladesh between Bangladesh and Italy in a collaborative project. Today I'll be staying with you to present the seminar and conducting the seminar with Professor Dr. Mizanur Rahman sir. He is the coordinator of Adar Health Bangladesh, and alongside Dr. Unu Singh Marma and Dr. Shirazul Islam, there are other members of Adar Health Bangladesh. They will help me in the technical problems. Now I request the audience to share the relevant questions regarding the lumpy skin disease on our Facebook page or YouTube channel in the comment section, so we can discuss these questions with our experts. Now, without any further ado, I would like to request Professor Abdul Samad sir for his presentation, and thank you very much.
Can you see my slides now? Hello?
Visible, sir? Sir, the slide is not visible. We cannot see the screen. So would you please try to share it
Yeah,
again, sir?
yeah, I'm doing that.
Okay, sir. Thank you, sir.
Can you see now?
Yes, sir. I can see your browser in your computer browser. I think you can minimize and show your desktop. No, sir. Now again, there's a white screen. We cannot see it, sir.
No, what's happening?
So if you can share the presentation to me, then I can also share it, sir,
I'll
from
just
here.
try once. No, last time.
Okay, okay,
Else,
sir.
no,
Sure, sir.
I'll share it with you.
Okay, sir.
Go to share screen. Then I'm going to window. Share. Now, can you?
It's still the same, sir. We cannot see your desktop.
Okay, I'll share. On the email address.
Okay, okay, sir.
Can you give me your email address?
Yes, sir. In the same mail, you can share the same mail of Unu Singh. You can share the here. You can reply with the
Yeah.
yes, sir. In this email, you can reply with the job.
Have sent.
Okay, sir. Thank you, sir. I'm just checking it. Unu, can you share the presentation, please? Unu, can you please share the presentation? I think you have received the presentation through email.
Yes, sir. I'm downloading the file.
Okay. Or you can also forward here. Yeah. Not this one, Unu. Onu, did you find it?
Can you see my screen?
Yeah.
Okay. Okay. Thank you, Uno.
So go on the presentation mode. Don't play picture in picture. Then the slide will be very minimized.
Sorry, I apologize for the technical inconvenience. Sir, you can start now. The presentation is showing, so you can start from here and we can go to the next slide when you guide us when it's done. Thank you, sir.
Now I can't see the slide.
So you can come to the estimate window and you can see the slide, sir. Can you see it, sir?
Mm-hmm. I see the slide, but it's saying picture in picture. Yeah, now I can see.
Okay, thank you, sir.
Okay. I'm extremely sorry for this technical hitch. I'll try to make up with the time. So welcome to today's webinar. At the outset, I would like to thank Dr. Mizan and Udder Health Bangladesh for giving me this opportunity to interact with you. So today we are going to discuss lumpy skin disease complex and the staging which we have developed to assist treatment decisions. Can I have the next slide? Now, my entire presentation is based on the recent LSD outbreak in Maharashtra, and this experience was also taken by other states. I'm presenting the outcome of what, along with the field officers, in some states we have been able to achieve. The whole idea was that we all know that once there is lumpy skin disease, we'll have to live with it for a very long period of time, and therefore there has to be some uniform protocols for attending to these cases. And as the name by itself suggests that it's a disease complex, so that means it's a syndrome and consists of different pathologies leading to different kinds of syndrome, and those are to be handled differently. The problem we faced in Maharashtra initially when the outbreak started was that, unlike the experience in COVID-19 outbreak, we found that the animal husbandry department was not really communicating with the farmer and the vets and the vets so effectively as we had seen in COVID-19. In COVID-19 outbreak, what used to happen was Indian Council of Medical Research, the Central Department of Health and the state departments used to hold joint meetings quite often, at least 2 to 3 times in a week, and they used to give information about the spread of the disease and how it is being tackled, what are the antibody levels and different kinds of information, and that was giving a lot of confidence to public. But when it came to lumpy skin disease, farmers were absolutely left in lurch, and not much information was being passed, and the information that was passed was only from the vets who were attending to cases. But one thing good was that the entire department staff was mobilized, and also because the staff condition was low, so even the retired livestock development officers and veterinary officers were also taken on board on contract basis, for solving the issues related with COVID-19. Then when the veterinary officers started insisting, the department came out with a SOP, and that SOP was very half-heartedly developed, without considering the actual field cases that were being reported. Then the university came up with another SOP, which also had a lot of elements which were not really rational, which they could not explain, and that threw lots of confusion in the vets. As a result, people tried homeopathy, people tried herbal, someone tried cow urine and started saying that even cow urine is helpful. Someone used cow dung and said that if you apply cow dung on the lesions, the lumpy skin disease goes off. So all kinds of these reports started, because there was an WhatsApp group that was formed. So there were two lumpy skin disease groups were formed, and the information was being exchanged within the two groups. There was no financial support also, because the medicine supply was very limited. It was only government supply, but the SOP we were suggesting were requiring different kind of medicines. So ultimately what I did, I used my own connections and approached a local NGO, Bombay 𝐲𝐷 Mandali, and asked them to give us some funds so that we can develop 2 or 3 different protocols, try out in the field, and then collect the data, and then finally come out with an SOP which is working. So that is how this entire staging and the SOP was developed. So can I have the next slide? Now, as you all know, that it's a very virulent pathogen, and it's a pox type of virus, and we know that pox and a family of viruses are quite virulent, and they cause a variety of syndrome. Their severity depends on immune reaction mounted by the virus and the evasion mechanisms of the pathogen. So it's a kind of fight between the virus which has entered the body now, and because of that, the body is now mounting an immune response. So it's a struggle between the virulence of the virus and the immune response that is leading to different kinds of syndrome. And many times we have seen that the most severe symptoms are because of severe immune response from the host. Whereas we know that pox viruses are virulent, and they have cytopathogenic effects. So they have lots of effect on different tissues and organs. Now, if you look at the sequence, nucleotide sequence, you'll find that there's lots of homologies, between different pox viruses, and it's around 180, kbp DNA, and out of which, around 90 to 100 genes are the one which are really functional genes, and the rest of the genes. And when we consider homology, we find that there is a lot of homology. So that is the reason why there is corrosive activity, and in areas where lumpy skin disease vaccine is not available, even other pox vaccine could also be used. So in Maharashtra, we have used in some areas goat pox vaccine, and in some areas we have also used sheep pox vaccine, but largely it has been goat pox vaccine which has been used. So when I'm describing all the treatment protocols, please bear in mind that the most important part in lumpy skin disease is controlling. Therefore, I'm not belittling control measures. Vaccination is extremely important, and vaccination must cover at least 80 to 85% of the population rapidly. Another important thing, which you must keep in mind while vaccinating, is there should not be a lot of gap, between different regions. Because if you would like to throw out the virus from the population, the most important thing is that major proportion of the population should be at the same immunological status, and that is possible only when you are vaccinating animals very rapidly, and not that one set of animals are vaccinated in 1 month, and then after 2 months you are vaccinating another set of. So that might prevent or control the severity of disease in the animals which have been vaccinated, but that will not help the outbreak to vanish. So for that matter, vaccination is important. So please keep that in mind when we discuss the protocols. Next, please. Now, the immune response in pox viruses is very severe, and as I've shown here, that there are genes which are going to code for different molecules, and these immune molecules are the one which would allow the virus to evade the immune response, as well as also cause stimulation of immune response from the host. So as I've said earlier, it's a balance of the two, which will ultimately lead to win situation, whether it is the host which is going to win or it is the virus which is going to win. Remember, whenever even in Maharashtra, we have found that during the outbreak, 70% of the cases will be the one which will get resolved even without any treatment. So they would go through a very mild symptom, and after those mild symptoms are gone, then you don't find any problem with them. Now then, out of the 30%, we find that there are cases 10 to 15% which would have some amplification of the disease, and they would show certain sets of symptoms, and then another 15% will go to very severe. So what I'm going to describe is all the three stages in which we have developed a protocol which will help you not only for diagnosis but also for undertaking treatment. So initially, when there were no SOPs, or the SOPs from the state government were being followed, or from the university, the mortality rate was very high. And one of the reasons was that the protocol was very heavy on drug side. So it was quite expensive for the farmers to buy 5 or 6 different kinds of injections, and a lot of weightage was given on antibiotic treatment, even though we knew that it's a viral disease and those antibiotics do not have any effect on the viruses. Therefore, we started very heavily on the diagnostic side, and then we also started searching out on research to find out what exactly is the pathogenesis for different kinds of syndrome which we are seeing. Can I have the next slide, please? And then we found that there are certain references where lumpy skin disease has also been recorded in human. But fortunately, here in Maharashtra, we did not record any case of lumpy skin disease in the volunteers or the doctors who are working. Although we did record in, I think, 4 or 5 volunteers and the doctors treating lumpy skin disease, herpes like infection, and the medical advice and the medical diagnosis was also herpes. And if you go through the literature, you will find that lumpy skin disease always has complicity with herpes virus. And there is a theory, and there are 2 or 3 papers which have been published from medical side, wherein they have shown that if there is a latent herpes infection, which is also very common in animals. So when there is a herpes, latent infection, then that aids lumpy skin disease virus to multiply faster, and therefore there is always an interaction between the two. And it is also known that lumpy skin disease also goes through mutations. And in recent Indian outbreak, it was found that the lumpy skin, the virus was having around 5 different mutations, because of which the disease was very severe. The virulence of the virus was very severe. Although although the literature said that zebu cattle, that is the Indian breeds of cattle, are relatively resistant, but we found that the disease was very virulent. Large number of cases were recorded in indigenous breed. Cases were also recorded in crossbreds. The severity was also more. We also recorded cases in calves, and there were a variety of symptoms which we could see. Now, as far as human is concerned, I've shown you, certain lesions which are found, but mostly these cases have been recorded in butchers, as well as in workers who are dealing with the leather industry. So those who are handling the skin and hide of animals that have suffered from lumpy skin disease. And since this leather industry is quite aggressive in Bangladesh, so this is something which needs to be taken into consideration. And this message of lumpy skin disease should also go to the medical staff who are like community workers who are working with these butchers and other workers who are in the leather industry. These lesions are very painful. It is edematous. There is lymph node enlargement, and if treatment is not done, there have also been deaths recorded. So I went through the protocols of treatment which was being given to human, just to understand what could be adopted from their protocol and applied to the animal side. Can I have the next slide? The problem with the SOP which was circulated in Maharashtra as well as from the central government was it was largely based on OIE protocol. And OIE and FAO have recommended certain initial treatment, but the problem is OIE also suggests that animals that have got skin lesions should be eliminated from the population and compensation should be paid to the farmer. They do not recommend treatment of cases, because once the virus has gone to the skin lesions, it remains for a very long period of time. The shedding of virus will remain for a longer period of time, and therefore the disease-free status will be very difficult to achieve. But as you know, in India, it's very difficult, because we have got legal laws, where large animals like cattle cannot be eliminated, cannot be slaughtered, and therefore this OIE protocol was of not much use to us. But that is what the national government insisted, that you only follow the OIE protocol. But we developed a protocol and circulated amongst the veterinarians, and in different stages we tried this and came out with a model for treatment. Can I have the next slide? Now this is the classical paper which I referred, because much of the work on pox, smallpox is not possible because smallpox has been eliminated. Therefore, the murine pox is the model which has largely been used for conducting any research on pox viruses. Now, pox, smallpox is although eradicated from the earth, but there are always concerns that it can emerge anytime. So there is a group of researchers in United States which have been actively working on smallpox variola virus, and they have in one of the papers they describe different stages wherein the pox syndrome would be you will able to see in the in the animals that are affected with the virus. So you can see the first stage on the top is infection, where the virus enters the body, and then the second stage is host virus interaction. So this is the time where there is immunological response and certain signs will be seen, certain symptoms will be seen. Now remember, these symptoms are an outcome of the immunological response of the host. And therefore, a large group of people suggest that at this stage, if you do any treatment, any aggressive treatment, you also interfere with the immunological response. And therefore, the immunological response will not be mounted properly. And the virus for some time may go and hide somewhere. And then there would be an amplification phase, sometime later, which will cause more damage than the first phase. So in the staging, what we have suggested is that this particular stage has to be identified properly. And we have also developed some markers for it. For example, for stage 1, what could be the the biomarkers or the marker which will tell you that the animal is in which stage. That also has been developed. So that will also assist you in diagnosis of the stage at which a particular animal is. And then the third stage is outcome, where either it is going to be recovery because the immune response is quite strong and the body has taken over the virus multiplication and the virus has been eliminated from the body, and therefore now there is no symptom. So around 70 to 80% of the animals will be in this stage where recovery will take place with the initial immunological response in within 3 to 7 days. But as I have told earlier, 30% cases, will go to an amplification stage, and then you'll have syndrome, which will be like coagulopathy syndrome, and then you have another syndrome which is thrombosis or cardiac signs, where you have got right ventricular failure, lung edema, and other kinds of complications. So let's go to now the different stages, and I'll describe and then the treatment which we have suggested to be carried out. Can I have the next slide, please? Now the incubation period is around 3 to 4 days. Of course, this will depend on the immunological status of the animal. And this is the stage we call it inflammation and immune response. This is the first stage. So you need to identify, whether a particular animal is in the first immune response stage or not, because here you have to find out whether you would like to really give any anti-inflammatory drug. This is where many people erred, and then when we pointed out to them that you are interfering very early in the immune response stage, and that is why you are having animals that are lingering, and then they are going into second and the third stage, and they are the one who are getting very serious. So when we suggested to them that not much is to be done in the first stage, except finding out what is the stage, and at that stage, depending upon the severity and the pain the animal is suffering from, then you'll have to give some palliative kind of treatment. Now the second stage is where the virus evades the immune response. Now here the virus is successful, it has evaded the immune response, and now there is a cytokine storm. So this cytokine storm is very similar to COVID-19. Now this cytokine response is, lots of cytokine in response to the cytopathic effects have been generated in the body. And now these are the ones which are causing different cytopathies, different organopathies, and we are going to see different symptoms. So here again, the most important syndrome which we have recorded here is the cardiovascular signs leading to edema in lung as well as different tissues, and also fibrinolytic syndrome, where because of fibrinolysis you have spontaneous thrombosis, just like what you see in disseminated intravascular coagulation, and that leads to different kind of complications which we will discuss later. Now this ICF complex then graduates into what we call as the chronic stage, which is cachexia, generalized edema, and then if most of these animals will die of different kind of secondary infections, bleeding, then the wounds which are very extensive, and those who survive will remain cachexic and have different complicating signs for a very long period of time. So basically these are the three stages. As I have said, the first stage, immune response stage, where it is only the virus which is multiplying and body is responding. The second stage, second stage is one, which we call it ICF, stage. The ICF stage, I'll describe, what are the symptoms. And then the third stage is the complicating stage, wherein you have cachexia and lingering type of, lesions and symptoms like you see in dengue fever. So can I have next? Yeah. Now we look at pathophysiology, and you find in the initial phase, in the initial phase, there is viremia. And and with viremia, there is, as I've said, immune response, and because of which there is continuous fever. Fever is very high. We have seen fever 104 to 107, and this lasts for 3 to 4 days. And in number of cases, we find that there is a transitory type of nodules that develop on the skin, and then after 3 to 4 days, fever subsides, even if you don't give any treatment, and the nodules also subside. So these are about 70 cases, and in this stage there is lacrimation, lymphadenopathy, and mild skin lesions. So this is the stage where we say that you should have bare minimum medicinal intervention and allow full-fledged immune response to happen from the animal body side so that it recovers fast. Now in this stage, the biomarkers are fever, and then another biomarker which we have looked at is the calcium reactive protein, CRP. Now basically CRP is an inflammation response, in inflammation responding marker, and this will be as there is infection and inflammation, the level will go up. So we have found that in the first stage, the CRP level is less than 100 microgram per ml. So we suggested to our vets to get in touch with different laboratories. Those were also medical laboratories, and we told them that the only thing which you need to do is take out blood and find out what is the CRP level. And if CRP level is less than 100 microgram per ml, don't worry. If the fever is very high and if there is any problem, you have to only minimally you have to interfere by giving certain medications. Now in the ICF phase, what we generally see is pulmonary edema. Then there is very severe inflammation, and there are coagulopathies, and because of these coagulopathies, you see lumps developing, lumps of thrombus developing at different parts of the body, especially on the on the terminal part of the body. For example, legs and the ear and the head are the one which are mostly affected. You have lumps of blood clots which will happen, and then fibrinolytic syndrome, because of which animal might go into bleeding and other kind of complications. And here we have suggested biomarkers to be calcium reactive protein more than 200 microgram per ml. And then to find out whether there is coagulopathy, we suggested a test which is very commonly done in human. It's called D-dimer, and this is available in any good human pathology laboratory. And we say that if D-dimer level is more between 200 to 500 nanogram per ml, then you have to think of intervention, because here the coagulopathy might result into different complication and animal might die. Whereas the fibrinogen level between 5 to 7 milligram per ml of plasma, if that is the level, then exceeding that, then you'll have to think that there is a fibrinolytic syndrome. So this is what we suggested to them in protocol, that in the once the case comes to you, and when you find that it is in initial phase and the farmer says that there is a fever since last 2, 3, 4 days, so just wait for another 2 days. If you find there are skin lesions, then you can just collect the blood sample, send it for CRP, and if CRP level is less than 100 microgram per ml, don't do anything. And if it is more than 100 microgram per ml, then maybe you can give some medicinal intervention, whereas other biomarkers can be done, and you can find out at what stage a particular animal is, and the treatment which has been suggested can be carried out. Next, please. Now, the treatment approach in viremic phase. Now, one thing should be remembered here is that there are papers that are suggesting that once there is viremia, this virus has to be eliminated by the an animal's immune response. So vaccination antibodies will not be able to take care of this, precisely for the reason that after vaccination the antibodies will develop quite late, and initially that would be of IgM type of antibodies, which will be getting converted to IgG in the later stage. Therefore, considering this fact as an important fact, that you have to allow the animal's body to overcome the virus infection or viremia, you'll have to see that you don't interfere in immunological response. And as I have said here, the indicator is fever, and then the calcium reactive protein, nasal discharge, and other things. For the first time, we suggested that we should also try antiviral. And as we had seen that in human LSD syndrome, they had used acyclovir successfully. Acyclovir is an antiviral drug, which is available as injectable as well as in oral form for human patients. So we said, let's try acyclovir, and the whole idea was to see that the viral load is brought to some extent so that the animal body would be able to overcome it. Because what happens if there is rapid multiplication of virus, because the immunological response is weak, then the virus, because of sheer the numbers, will overtake the immune response. And there, if you give antiviral drug, the virus will be killed, and then as the virus load comes down, the immune response is much better. So that was the idea behind starting acyclovir. When we suggested acyclovir, there was a lot of resistance from the government side as well as from the state government side, suggesting that acyclovir nobody has used, so we don't know what are going to be side effects. But since we insisted that as this is already available in human, it is used extensively without much side effect. Therefore, we should see whether this is going to be effective. So we must have used acyclovir in more than I think 5,000 animals now, and the response from the field vet was, the moment they started using acyclovir in lumpy skin disease, the mortality went down drastically, and then we found that the recovery was also much faster. So starting acyclovir or antiviral drug as early as possible is important, and generally we say that if the body temperature is more than 104 degrees Fahrenheit, then it's better to start acyclovir. And another recommendation was, if it is a calf, then you don't have to wait even if it is 103. And if calf is having initial nodules, straightway go for acyclovir. So we have got number of cases where the virus load was so much that the calves were having seizures, nervous signs, and almost the the farmers had given up that this particular animal will not get up. Even large adult cattle also in very severe stage, were having very high fever, severe pneumonia and other complications. Once we started giving them acyclovir, we found very good results with them. One thing we insisted on all the vets was not to use non-steroidal anti-inflammatory drug like diclofenac or meloxicam. Earlier, people were using meloxicam very extensively right from the first day, and what was happening was because they were trying to depress the fever, the immune response was not getting mounted, and large number of cases were getting into second and third stage. So we said absolutely no cortisone, absolutely no non-steroidal anti-inflammatory. If there is high fever, we suggested that you can give simple paracetamol. Paracetamol can also be given orally, because orally paracetamol in ruminant is absorbed to some extent, and there are also injectable paracetamol available, and injectable can also be given. So that was what most of the vets were following that. They were giving paracetamol simply for 1 or 2 days to bring down the fever to some extent, from say 106 to 104. And after 104, we told them not to worry, because fever is not such a big issue. What we need to do is lower. We have to see that the virus load goes down. Then check the severity of skin lesions. If these are few and mostly wild, then in that case just go for CRP, and if CRP is not very high, leave aside, because those skin lesions will resolve by itself. And some people suggested that there could also be bacterial infection. So we looked at some data where we found that if the CRP level was more than 300, in that case we suggested that that is suggestive of also secondary infection. So you might even try some antibiotic, and some long-acting antibiotic were tried in some cases. But in most of the cases later on, we told them not to try even antibiotic, because it's a viral disease, and there are other ways of getting rid of the virus. Usually the first phase remains for 7 to 10 days. But then we found that there were a lot of cases where initially we found that there was resolution. Then there was a phase of 7 days to 10 days where the animal was perfectly normal. And after that 7 days, 1 week or 10 days period, again there was severe fever. That is the amplification stage, where the viruses has now mounted a severe attack on the immune response, and that is where then the other complications like edema and cardiovascular signs would develop. So to simplify, in the first stage, it is the viremic stage, and viremic stage we have to differentiate whether the inflammation response is too severe as to cause problem to the animal's body, and that you can do with the help of calcium reactive protein level. It's a very simple test which can be done at any medical laboratory, and that will give you an idea whether you have to give antibiotic or not, and whether you have to give paracetamol or other antibiotic drug. Second thing, we suggested to them that irrespective if it is cough, then immediately go for acyclovir injection for 3 to 5 days at the rate of 5 milligram per kg body weight. In case of young calves, we suggested that even oral acyclovir can also be given as follow-up, whereas we know that acyclovir is not absorbed from rumen when it is given to adults. So we were insisting that at least twice acyclovir injection should be given for 3 to 5 days, and we got excellent results with acyclovir. So can I have the next slide? So this is the acyclovir. And acyclovir is a broad spectrum antiviral drug which is approved by FDA, and I think it's very commonly used even in pet animals in USA, Canada, as well as Europe. It's used in herpes infection in pet animals, and it's also used in humans. So we can also use it in case of large animal. The basic problem with acyclovir is its half-life is short. And that's why in case of human, if the injection is to be given, they give injection at least 4 times in a day, which is not possible in animal patients, because vets cannot visit. And then intravenous infection is more intravenous acyclovir is more efficient than intramuscular. Therefore, it becomes very difficult. So what we have done with the help of the pharmaceutical pharmacy colleges here, we have launched a program where we are developing acyclovir oral for ruminants. We have a microencapsulation technology wherein we can encapsulate any drug in it, and the polymer which we use for encapsulation is rumen fermentation resistant, and it will target the drug or the molecule directly to the intestine where it will be absorbed. So this particular development is in a very very advanced stage, and we are now doing kinetic studies. So once we have acyclovir oral also available for adults, I think we should be able to take care of huge viremia which happens in the initial stages. Can I have the next slide? Another drug which is suggested by Government of India as well as the state government, and I think OIE is also suggested, is methylene blue. Now, remember, methylene blue, if you want to use it, it's an antiviral. It's a very known antiviral drug. It has got very large spectrum, and it's a very old drug, which has been used in number of protozoan infection like malaria. It's quite cost effective. It's very cheaply available in the market, but there are some problems with methylene blue. The government of India suggested that methylene blue should be given orally, as 10%, 5% to 10% solution to be given orally. But when we try to find out, methylene blue is a stain, and when we try to find out, what happens if I give methylene blue to ruminant? So what happens to the rumen microflora, or rumen protozoa especially? Are they also stained with methylene blue? But there was no literature available on methylene blue on these aspects. Another thing we found was methylene blue is excreted very fast, so that when you give methylene blue even orally or intravenously, you find methylene blue would appear in urine. So blue urine will be passed within 15 minutes, suggesting that it's being passed through the body very rapidly through kidneys. See, methylene blue is a very highly charged molecule, so therefore its half-life in the body is very short. But we also found papers suggesting that if you want to use methylene blue in case of cows, then intramammary route is much better, because when you give intramammary route methylene blue, it is not going to pass through that liver, so it will go directly into the circulation, and there it has been shown that methylene blue level will remain for a longer period of time, around 4 to 5 hours. And since methylene blue can easily be given by farmers, so even if it is to be repeated 3 to 4 times, you can teach the farmers to have 15 ml of methylene blue or 30 ml of methylene blue, and you can inject this in one teat, and there is very rapid absorption from mammary tissue, and it will appear in blood very fast. Now, another, as I've said, with methylene blue, the problem was that short life is the main problem. So we have again contacted a nanotechnology center in Aligarh Muslim University. I have a friend over there who is the director, and he is a renowned name in nanotechnology. So he uses different types of fungus, and the beauty of that model is if you feed anything to those fungus, which culture which he is maintaining, the fungus will convert that into a nanoparticle and will throw it. And he has got a large number of cultures where, depending upon what size of the nanoparticle you want, you can use different cultures. So I had asked him to give me methylene blue of 50 nanometer to 100 nanometer size, so that it becomes a long circulating type of drug. And recently he has shared with me some nanoparticulate methylene blue, which I'm currently using for my testing purpose. So these are two good developments that is taking place. And since there were problems with the cost with 𝐒𝐳, so what we came out with a model was that initially when a vet visits, he would give say 𝐒𝐳 intravenously, and then he will prescribe methylene blue oral or intramammary to be repeated every 6 hours by the farmers. And that was the combination of 𝐒𝐳 and methylene blue, which we took up for lowering the virus load in the initial stages. And with that, we found that the mortality rate which was hovering around more than 10 to 12%, was drastically reduced to less than 1.5%, and recovery was much faster. So this is one lesson which we learned from this field experience, was that in the initial stage you can use both antivirals, 𝐒𝐳 as well as methylene blue. Can I have the next slide, please? Now, as I have said earlier, that once you have taken care of initial viremia, you have to be very vigilant that the animal is not going into amplification stage. So generally, we suggested to the paravets working in the field that on 14th, 15th, and 16th day, ask the farmer to take temperature, rectal temperature, and if there is rectal temperature is high, that means now this particular animal is going into amplification stage. And once it gets into amplification stage, then it is going into different complications, which you need to identify as to what is the complication, and then accordingly you have to take treatment. A lot of errors were made in between. People were giving medicines which were not really relevant to the pathology, relevant to the basic cause, and that's why, although the farmers were spending a lot of money, but they were not getting much result from the drug which they were using. So the major crisis in this phase is cytokine storm. And this cytokine storm leads to coagulation defects, exactly like you must have read, or you must have read the articles on COVID-19. So very similar. All the viruses, they have in the second stage, cytokine storm. And if you're not able to, take care of the cytokine storm, then there are, lots of complications, including the, organ failures. And these, cytokine storm leads to vasculitis and lymphadenitis. Then there is disseminated intravascular coagulation and deep vein thrombosis. Deep vein thrombosis, we have found very extensive in those, 15% of the cases, which get into the amplification stage. And what happens here, that there is in deep vein thrombosis, in the terminal veins, you get coagulation. So there are lumps of blood coagulation which take place, because of which there is no efficient venous return. And when there is no efficient venous return, then the viruses having cytopathogenic effect will have an effect on the local tissue. There will be local tissue injury, and the congestion which is happening at the lower limbs would lead to swelling in the limbs, as well as swelling in the brisket edema. We also found that brisket edema was also a very common finding in the initial stages. So most of the cases we found that which went after 14, 15, 16 days into the amplification stage, initially had severe skin lesions, followed by lymphadenopathy, and then they had brisket edema. And this brisket edema is also accompanied by pulmonary edema. So if you do the auscultation, you'll find fluid accumulated in the lung. It is not in the cavity, thoracic cavity, it is in the lung. So it's a pulmonary edema, and that is because of the right ventricular failure, and that is happening because of the thrombosis and the effect of the viruses on the heart. So then we developed a protocol of taking care of this right ventricular failure. So we decided a set of treatment to be adopted. Now here again, for coagulopathy, as I said earlier, we developed and standardized a marker called D-dimer test. So we told them that after 14, 15, 16, if you find that there is fever, immediately you should go for CRP as well as D-dimer. And depending upon the level of CRP and D-dimer, we'll have to differentiate whether it is going into fibrinolytic stage, or coagulopathy, or it is only in the right ventricular failure stage. And accordingly, then treatment is to be adopted. So if CRP is more than 200 microgram and D-dimer is more than 500 nanogram, then it is indicative of coagulopathy crisis. And here, if you do not intervene properly, then the coagulopathy is very severe, and most of the animals will die in this stage. And we found that there are very efficient drugs that are available in human, and that can also be very efficiently used in case of animals, so that I will also be able to describe to you. For example, for disseminated intravascular coagulation, we found that injection of heparin at the rate of 300 international unit per kg subcutaneously was found to be very useful. So we told the vet that the moment you find that there is DIC, and in DIC you have a D-dimer level which is more than 500 nanogram, the first thing you should do is give an injection of heparin as a preventive step at the rate of 300 microgram subcutaneously, and that will resolve DIC. And at this stage, you can also use methylprednisolone, because here what is happening is the cytokine storm is also leading to thrombocytopenia, and this thrombocytopenia becomes life-threatening for the animal. And here you'll have to give prednisolone, even though prednisolone is known to be immunosuppressive kind of drug, but here you do want immunosuppression. But again, here we told the vets not to use non-steroidal anti-inflammatory drug in combination with either methylprednisolone or dexamethasone if they want to use, but never to be club this with non-steroidal anti-inflammatory drug. Can I have next slide, please? Now you can see that these are the cases where there is you can see brisket edema. Now, if you see brisket edema in lumpy skin disease, then this is mostly because of right ventricular failure. And here you will have to and this right ventricular failure leads to pulmonary edema, and pulmonary edema in turn is because of the interfered venous return. So we have found that injection of digoxin to improve the contractibility of heart helps here, along with diuretic. Now in diuretic also we found that furosemide, which is very commonly used in case of veterinary practice, was not really very useful. And we found out that there is second generation diuretics, it's called torsemide, is quite useful. So our large number of vets, instead of furosemide, shifted on torsemide to be given intramuscular injection, and also started using digoxin, and with that they found that the brisket edema was resolved, and the contractibility of heart as well as pulmonary edema was also resolved. Another picture which I am showing you on my right side is you can see the swelling of the limb. Now this swelling of the limb is not because of the edema. There is edema, but the major reason of this edema is deep vein thrombosis. And you'll know that even in COVID-19 and other viruses also, wherever you have a cytokine storm and you have coagulopathy defect, you will have these kind of lesions where there is swelling, and this swelling is because of the defective venous return, because of thrombus on the far limb. So you'll find that there is thromboemboli, and those thromboemboli is interfering in venous return, because of which the the fluid oozes out, and there is and you can see that there is also swelling. Now such cases cannot be resolved only by giving diuretic, because what diuretic will do is only remove the fluid, but here, because there is already thrombosis, diuretic is not going to be effective. So here you will have to use some drug which will resolve the thrombus. And we found that there are two different drugs which we used in two different sets of animals. Initially we started using heparin, as I've said earlier, and that heparin was 300 international unit per kg subcutaneously, to be repeated as often as possible. But sometimes the vets reported that because of heparin injection, they were also having problems related with bleeding. Although there is a good antidote available for heparin, that is protamine, and if you give protamine immediately, it's a miraculous type of antidote. As soon as you give protamine, any ill effect of heparin will be taken care of. But the vets were very apprehensive, because after giving heparin, they would go back to another village, and by that time, if they receive a call that there is now bleeding, it's very difficult for them to write back. So then we developed another protocol where instead of heparin, we started using a drug which is called warfarin. Now warfarin is another very good thrombolytic drug. It is available for human, but it's not available as injectable. But fortunately, we found out in literature that warfarin given orally in ruminant is also absorbed. So we developed a protocol where we started giving warfarin at the loading dose, and then slowly lowering it over a period of 1 week. So the loading dose here was 20 milligram. So this is available in the market as 5 milligram tablet. So we were giving 4 tablet initially, for 2 to 3 days, followed by another 2 to 3 days 15 milligram, followed by 10 milligram, and with that we found that this there was very effective thrombolysis, and the edema of the brisket as well as edema of the limbs was resolved very fast. Another problem which we found was, if you are not giving warfarin or heparin to take care of edema which is due to thrombosis, then it will develop into because of the occlusion in the blood supply, there will be necrosis, and necrosis, will lead to very huge, wound, which will be in the terminal stages, and then taking care of, those wounds becomes very difficult, because those are very, very extensive exfoliative kind of, wound, which I will be able to, show you later on. So here the protocol was that if you are having brisket edema, and then if you find that heart rate is high, there is tachycardia, then you said, okay, you go for digoxin to be given 0.025 milligram per kg body weight, at least for 3 days. Check for heart rate. The heart rate should come down, and then followed by either heparin or warfarin, and in the loading, doses, and the tapering one, and then within 2 to 3 days, the brisket edema should resolve, and in another 6 to 7 days, the edema of the limbs, should also get resolved, and the animals, should be, back on the on its feet as normal, healthy. So with this protocol, we could save large number of animals, even very severe cases which the farmers and the vets had lost hope that they will not be able to treat these cases with very simple staging and very intelligent kind of treatment strategies. We were able to resolve even those cases. So can I have the next slide, please? And I'll not go into detail of the right ventricular failure, how it is to be how it is to be tackled. But as I have said, there are two things you need to do here. Number one, you have to give diuretic, which is very effective, and the effective diuretic in case of lumpy skin disease. And we have also used torsemide now in other applications also, where there is, let's say, mammary edema or submandibular edema because of some other disease, and we find that torsemide is at least 10 times better than furosemide. Furosemide has a problem of hypokalemia, because there is a loss of protection, but with torsemide you don't have that problem. Furosemide, you can't give daily, because then the animal becomes very weak, and then it will sit down because of hypokalemia, and there will be other complications. But with torsemide, you don't have that kind of problem. Torsemide is long acting, so you can give every alternative also. So I think the vets can also adopt torsemide as another alternate diuretic, which if it is available in Bangladesh. Then second thing, we said that if there is tachycardia, and tachycardia is more than 100, the heart rate is more than 100 per minute. In that case, the venous return is less because of tachycardia, so you have to increase the contractibility. And for increasing contractibility, you have to use digoxin. So there are 3 districts in eastern part of Maharashtra where the vets have treated more than 1,000 cattle with brisket edema and right ventricular failure with digoxin. Initially, they were very apprehensive, thinking that if we give digoxin, there will be a lot of side effects. But when I told them that you don't worry, just keep an eye and tap on the heart rate, and give digoxin very slowly, intravenously, but not to be given orally at all, because it is not absorbed. So that helped along with the torsemide. Next, please. So this is in short, the staging, which we developed along with the symptom as well as the biomarker and the treatment, which is to be given. And this is what most of the vets followed in Maharashtra. And this protocol was also shared with other states. And although officially the SOP circulated was different, but people have used this and communicated to me, because we had number of WhatsApp groups, and I had since I had taken funds from an NGO, and I had promised them that after doing this field studies, we will be giving them report. So I had insisted on all the vets to share the case papers, share the improvement that is happening, as well as the reports from the laboratories. So all those we were collecting as much as possible, and based on that this is the protocol which we have developed. And this particular protocol will in this slide will be shared on the website of Udder Health, so that you can always go back and refer to it. I would request that to diagnose a particular animal is in which stage and what treatment is to be followed. is very largely and critically dependent on the biomarkers which we have suggested. And those are the tests which are readily available in any medical laboratory. They are not very expensive, they are quite cheap. In fact, during the outbreak, we could make a deal with many human laboratories to give discounts. They give discount as high as 75%, 80% discount, and then these tests were undertaken. Then during this outbreak, I was also writing different blogs at different stages to advise. I think I have got 4 different blogs, right from defending acyclovir, because there were a lot of issues being raised even from the government officials about using of cyclovir. So defending use of cyclovir, I had to I wrote a blog. Then after that, I wrote a blog on how to tackle coagulopathies and disseminated intravascular coagulation, as well as right ventricular failure. And the third was on staging. So even those blogs also I'll share with Dr. Mizan, so that it will become part of the folder which you can store on your website, and people will be able to refer. So can I have next slide, please? Now these are other complications. So lots of I've got a large number of photographs which have been shared by vets, where number of complications, right from eye infections to keratitis, necrosis, open wound, all these things were reported. We also had large number of cases where there was complete anorexia, and these were the cases which really posed us problem, because the loss of weight was very rapid. The body condition score went down very rapidly. Animals were not able to eat properly, and they were not able to digest. And for that we said that we told vets that the farmers should be taught 2 things. One is large number of farmers were taught how to take rectal temperature, because the initial phase of the viremia, the initial phase of the disease is dependent on rectal temperature. Therefore, taking temperature if there is an outbreak by all the farmers for all the animals, during the morning time becomes very critical for reporting early cases. So that is one thing which you need to teach to the farmers, that the normal thermometer can be used rectally, and they can check what is the temperature. And the second thing, we also told them that 14, 15, 16, 17, these are the 3-4 days where again they need to take temperature of the animal. And the third thing we told them was nursing, that is feeding. Now here we found that one of the nutrient which we used in this outbreak was microencapsulated starch, because the pathology, the postmortem report also showed that the postmortem report also showed that there were extensive gastrointestinal lesion, because of which animals were not able to digest the cellulose and other feeding which was being done. So we asked them to start feeding rumen bypass microencapsulated starch, which is available in market as maize starch. And they reported that within 2 to 3 days of starting this particular nutrient, the animal started eating, and then the condition of the animal, the body conditions would also become relatively better. So taking care of the nursing part is equally important in this stage. There is also sharp decline in milk yield, and in number of cases we found that once the disease is over and the animal is settled, supplementing rumen bypass starch as well as rumen bypass glycerol also helped them in bringing back on the milk yield. Of course, it was not as per the earlier peak yield, but it was around about 75 to 80% of what the cows were giving earlier, which had become hardly 5% or 7% because of the disease. So feeding them certain strategic nutrient is important for taking care of anorexia and for maintaining their body condition score. Can I have the next slide, please? Now this is the the rumen bypass starch we are using, because if you feed starch directly or if you feed grains, they are fermented very rapidly into rumen, and then that will produce severe rumen acidosis, and further the dry matter uptake will be depressed. Plus the propionate which is formed from starch in rumen will be taken to liver. There it will be stored as glycogen, and then from gluconeogenesis it will be getting converted to glucose, and this glucose then will be supplied to intestine, and the repairing will take place, the lesions which are there. That is a very inefficient way. So instead we found out a way that we could give directly glucose as rumen bypass. So the starch which goes to intestine is converted to glucose from pancreatic amylase. So in this particular product there is also bypass protein and exogenous amylase which is added. So the conversion to glucose is complete, and animal gets recovered much faster. Next please. Next please. Now, I said, these are the complications of lumpy skin disease because of deep vein thrombosis. Now, if you do not take care of deep vein thrombosis at an early stage, then you have all this necrotic type of lesion which is exfoliative, extensive lesions. The whole the muscle mass as well as the skin mass will come out because of necrosis, and this necrosis is happening because there is thrombosis. And thrombus is occluding the blood supply, and if there is no blood supply, so naturally the nutrients will not go and necrosis will start happening. So this becomes another complicating factor which you'll have to take care of. And we found large number of cases, earlier cases when the acyclovir and treatment for deep vein thrombosis with warfarin and heparin was not being taken. Many of those cases went into this necrotic phase, and it became very difficult for us to start treatment. Fortunately, there is another because over here the basic problem is these wounds also shed lot of virus. So if these are not taken care, then these becomes the focus of shedding of virus, and then the virus will be spreading within the herd or between the herd. So the treatment here is we told them either to use methylene blue for dressing purpose, or to use acyclovir ointment if they feel that the viremia has been extensive and skin lesions are still there, and if there are skin nodules which are still existing, there is every likelihood that these wounds will also be shedding virus. So better use acyclovir ointment which is available in the market. And dressing became very difficult here. So we could find a good spray chemical dressing material, and this is the spray formulation which is two spray formulation A and B. So when you spray A and then followed by B, it forms a dressing film on the wound covering the entire wound, and that becomes a kind of film, and the film is such that it is discontinuous, but the pore size is less than bacteria size, that is 0.2 micron, and therefore bacteria cannot enter. Even if flies sit, it cannot lay maggots, so those complications will not happen. And the spray has got a lot of moisture entrapped, so it will keep the wound moist, and therefore healing is much faster. So we gave this spray to large number of vets, and they have used extensively in more than 500 animals having these kind of extensive wound, and they have reported 75 to 80% recovery in very extensive wound also. So can I have the next slide, please? So these are the cases which we have treated. So you can see the case on the left side, necrotic extensive wound. So you have to just spray A and B, leave it for 5 days. You don't have to really repeat it unless and until the film has come out, because the animal was sitting in water, etc. Although it is hydrophobic, it won't come out. You don't have to peel off like other films that are collagen films that are available as biodressing material. So there the problem is the biodressing collagen material which is already formed is to be put as a transplant on the wound, and once the wound is healed, then you have to peel off that collagen. But this wound spray, you don't have to peel off. It is not a pre-fabricated kind of collagen dressing material. When you spray it, it will it is in aqueous form, so it will spread very uniformly across the wound margins. And as soon as you spray the second spray chemical, a thin film will be formed, which will totally and entirely cover the wound, and recovery is much faster. So these are 2-3 development which took place because of this lumpy skin disease, and the need which arose to come up. And we had good contacts with the pharmacy colleges here, pharmaceutical departments, and we could collaborate with them and tell them that these are these are few things which we require. And fortunately they were all into these kind of developments already for human side, so we could adopt these technologies very rapidly for animal side, and we could supply free of cost to a large number of vets, because of which we could save a very large number of affected animals. Can I have the next slide? Yeah, so this is the lumpy skin disease wounds treatment, and we found that two antibiotics we found very effective, fusidic acid and mupirocin. Now these are available in the ointment form is available. So what we suggested to them was, first wash the wound with methylene blue or otherwise sterile water, put mupirocin ointment or fusidic acid ointment, and then spray A and B over it so that the wound is bandaged. So we call it chemical bandaging, and then give warfarin for 7 days at the loading dose and the tapering dose. And with that we found very good results, and even this very complicated wound also we were able to treat. Next please. Now these are some of the vaccination related problems. So number one, as I have said in my first slide, that if there is virus infection and there is viremia, do not depend that the immune response which will be mounted by the animal will take care of the existing virus. No, it won't take place. So therefore this vaccination which you are going to give is going to take care of the infection that is likely to happen in the next phase, or later on if there is an outbreak. So it's more of preventive, but it will not take care of the existing viremia. It takes 28 days to develop full immune response, and therefore the animal is very much at high risk in the early stages. So that is why we always insist that your strategy should always include ways and means to reduce the virus load. If you are able to achieve that reduction of virus load to 50%, then the animal's body immune response is going to be very powerful, and animal will not go beyond the first stage. So that is the message which I would like to give you very vociferously, that interfering with an antiviral, let it be acyclovir or methylene blue, should be at the initial stage only, and that is where the farmers' participation becomes important. So our vets also gave distributed methylene blue to large number of farmers, and told them how to prepare methylene blue for oral use, and told them how to take temperature, rectal temperature. The moment they find that the rectal temperature is more than 103 degrees Fahrenheit, we told them that you start giving at least methylene blue orally, communicate with the vet, and the vet would come and give acyclovir injection, and then subsequently take temperature at 14, 15, 16, 17, day 16, and then if there is fever, again start with methylene blue, and if there is complicating signs like brisket edema and limb edema is happening, in that case depending upon if there is tachycardia, take care with digoxin and torsemide, and if there is limb edema, then start with heparin or warfarin. So that is what we had told them. Now there are also people who reported that they have done goat pox vaccination in cattle, but not in goat. But they could see few cases in goat also, and a few goat pox cases in goat. So I don't know how that has happened, although the vaccination was done only in goat. But those are the reports. It might be quite incidental that there was also goat pox happening in that area, and some goats got the infection. Large number of people also reported protozoan infection, like Theileria and Anaplasma. And we told initially they were all treating for thalidomide and anaplasmosis, but later on we told them not to go for treatment unless and until you have got a 2 PCV done 3 days apart. And if you find that PCV is going down by more than 15%, in that case, and if the parasitemia is more than 10%, then in that case you can think of giving antiprotozoan. Otherwise, don't worry, this is all because of immunosuppression that is happening. And once the animal is treated, the protozoan infection will also be taken care of. So the key to control is to inform and involve the farms, taking fever, control of movement, biosecurity, and manure management. I find that in lumpy skin disease control, the manure management is not really finding a proper place. They are all even in India, they have all focused on vector control. And for vector control, what they suggested was spray in the farm, but that is not going to help. It will help only temporarily, because the major problem there is the breeding places of the vector, because manure disposal is not proper, and moist manure is being stored right at the farm itself, and it is not properly disposed of. The vectors are going to multiply there, and therefore unless and until you have got a strategy of manure management which is taught to the farmer, then only you are going to have vector control. Otherwise, once there is virus in the population, it will be very difficult, and there would be recurrent infections in the population. Can I have the next and last slide, please? Yeah, thank you.
Thank you very much, sir, for your very informative presentation. It was very interesting insights and also describing very comprehensively the pathophysiology of this disease and everything. And we have some questions, and then we'll start include other discussions.
Yes, Shubho, give the question first, then we'll go with the
Yes, sir.
Okay.
So on question was about, you can see the questions in the screen. So on question is about using the anti-SRAM treatment. Is there any evidence, or you think if it's effective or something about
See,
anti-serum treatment?
theoretically, if you have got an anti-serum against lumpy skin disease virus, it should work in lowering the virus load. In Maharashtra, a number of cases were treated where blood transfusion was carried out. In cases where there was thrombocytopenia and fibrinolytic syndrome. And then later on, another group came up with even separation of plasma. So they came out with a process where the platelet-rich plasma was separated, and that platelet-rich plasma was also given, in lumpy skin disease. And as far as thrombocytopenia and fibrinolytic syndrome was concerned, it was found to be quite useful. So those are the things which people have tried. But I think anti-serum and anti-sera is not available. At least in India, I have not seen anti-sera which is available. If it will be available, it will be very expensive. It has to be given very intravenously. I don't know how many times you will have to give. So better option here is to go for early detection of the virus load. And then with biomarker find out what must be the virus load, is it beyond the threshold, and then go for antiviral drug administration right at the first stage. So I think that is the winning strategy. If you are able to take care of virus load initially, you don't have to worry about complications.
Thank you, sir, for your nice explanation. There's another question. Another question is about the warfarin, if it's the total dose or this is the dose per kilogram of body weight.
No. 20 milligram is the total dose. Okay, and the and I think here the lethal dose for warfarin in cattle is 200 milligram. Total dose 200 milligram will be fatal for a cattle. So you have to be very careful that the total dose initially is 20 milligram for 2 to 3 days, and then you lower down the dose to 15 milligram for next 2-3 days, and then lower down to 10 milligram. Not reverse. Always go for a loading dose first, and then you'll find that within a week's time you will see that all the thrombi have been resolved and the circulation has started. So the limb swelling as well as brisket edema will go down drastically.
Thank you, sir. And then another question is about the spray. So the question is if the spray it's a substitute for acyclovir, or we should use it along with acyclovir.
We have come out with one spray which is having nanomethylene blue incorporated in it. So if you are using that kind of spray, which is having antiviral, then in that case there is no need of having acyclovir. Whereas if you are using non-methylene blue spray, that nanomethylene blue is there in spray A, and B is the one which is a polymer which will interact intercalate with spray A and form a matrix and the film, and there is also a reinforcement material polymer in A, so that forms a very flexible but very stable kind of film over the wound. If that is not available, acyclovir you don't want to use, you can wash the wound with methylene blue directly. Say 0.1% methylene blue, you just wash the wound and then spray over it. If you feel that there is bacterial infection, then in that case you can use some antibiotic like fusidic acid, which I have indicated. But the vets over here have reported that 90% of the cases there was no secondary bacterial infection, so they were able to take care of this extensive wound with use of just spray.
Thank you very much, sir. I think he has got the audience has got the right answer for the question. And then on final question was about some post-mortem findings. So sometimes if the diagnostic fails in case animal dies, we can possibly identify it as the case.
Sorry, I've not attended a postmortem, but I have read through papers on postmortem findings. But again, these postmortem findings will depend on the stage at which a particular animal has died, and usually death will happen either on the second stage or the third stage. So depending upon if it is a cardiopathy stage, where there is left ventricular failure, on postmortem you will find that there are blood clots in right ventricular, and then you will also find blood clots in arteries and veins. So that and then you will have lesions which is there on the skin, as well as lesions in the gastrointestinal tract, severe pulmonary edema, and lesions in the lungs. So these are the common postmortem findings. But when it comes to diagnosis, I think the symptoms are so classical that initially if there is an outbreak, and remember these cases will always be in outbreak form. So you will not be in a situation where in the population there is only one case which has come to you and then there is no other case. So as soon as you have cases, 2-3 cases or large number of cases reported to you, it's a notifiable disease in Maharashtra and India. I don't know the status in Bangladesh, but here the vet, after seeing a case and suspecting it to be lumpy skin disease, is duty bound to inform to his immediate officials, and then the diagnostic laboratories will come into picture. Then we have a lab in Bhopal, which is specialized in diagnosis of these kind of diseases. It's called high security veterinary diagnostic laboratory in Bhopal. So immediately there people would come to the field, collect the material, and they would isolate the virus, do PCR as well as do nucleotide sequencing, and within 2 to 3 days they will inform the diagnosis that it is a lumpy skin disease, and then the district officials will issue a notification. The district magistrate will issue a notification that there is a lumpy skin disease, and therefore there are restrictions on movement of cattle, which is taking place, and then the entire department will be moved on going to field and start getting treatment. So this is a very well oiled machinery which has been set up. So the response time for outbreak is now quite fast from the state government side, and the vets now have the protocol, so they are also now able to respond to the stage and the outbreak very very rapidly.
Thank you, sir. Then there's another question. It's about transmission. So if there's viral load is about 50%, because when the load is reduced at 50%, it can produce some level of immunity. So in that case, can the disease still be transmitted among other animals in that farm?
Yeah. I mean, this is the real problem in lumpy skin disease. That if there are dermal lesions, if there are skin lesions, and if the virus has crossed the circulation and gone hiding into skin tissues, then the virus will remain for a very long period of time. And as those skin lesions will start maturing, and the crust will be formed, and the crust in the farm that will be very rich in viruses. So that is a major source of transmission of virus into the into the population. Similarly, open wounds which I have shown are also source of virus. So therefore, they say that once you have a problem of lumpy skin disease, you are basically married to lumpy skin disease. So it will remain with you for a very long period of time, and that is why in many countries they follow a system where if you have got an animal which is having skin lesions, then that animal is not to be treated. It has to be slaughtered and disposed of, so that you get rid of the carrier animals. But in our part of the world, it becomes very expensive, because we cannot really compensate the farmers if there is a large outbreak. Therefore we have to go to a situation which is a middle path, where we should allow, and I'm particularly of the opinion that getting rid of any bacteria or viruses which are more intelligent than human is very difficult, and therefore we should allow also them to remain, and so that you find out a midway, that we sacrifice few animals, but the virus is also there, and the animal is also there, because I have seen even in North America, where they have eradicated disease, maintaining an eradicated status becomes more expensive and difficult than eradicating an outbreak. So there is a large thinking now really on this side. Should we really go for eradication, or should we go for a midway, where we find out that not much harm is done to the industry and the animal.
Okay,
Thank you,
sure.
sir.
I think Shubho, you should give time for the discussion here, and we have 20 minutes to finish it.
Yeah. See, autohemotherapy, somebody asked me, please avoid autohemotherapy. That is a very old theory, that giving blood improves the immunity is wrong. That is some old theory that if you take out blood in a glass syringe and keep it for few minutes, its receptors surface receptors are altered, and it becomes immunogenic. So it has absolutely no basis. Whereas in case of LSD, if you are doing that, you are not knowing whether the blood you are transmitting is really having latent virus infection. So instead of treating, you might be again re-injecting the viruses. So avoid that. It has got no rationale.
Thank you, sir. I think we can now go into the discussion section, and we can first request to Dr. 𝐻𝐸𝐺 Hossain, sir, and share him some practical experiences, and we can also get suggestions from Dr. Samad, sir, how we can deal with it.
Yes.
Thank you.
Sorry, Bhad Bhai, I think we are going to be 2 hours. So I request every one of us to be very specific, please.
Thank you, Professor Dr. Samar, for your nice presentation. We learned a lot of things about LSD complex. Really, it is a complex disease and economic important disease also. It is also a zoonotic importance there. But we have learned a lot of things. But in our country, laboratory facilities is very poor in animal health sector. That is, there is a CRP and D-dimer, etc., and other tests is needed. But we diagnose LSD in a clinical symptom, but we have learned a lot of stages there: first phase, second phase, third phase, and every phase there is a management protocol. Some treatment is there. So we also know the methylene blue is an antiviral drug. We use only it is our poisoning cases, that is. But methylene blue you also use in orally. How milligram per kg of in cattle methylene blue, and if it is used in intravenously, and dose should be mentioned again. So antiviral drug is also available in human use. We sometimes use it. Is it methylene blue is also acts on FMD or PPR or other disease like LSD? We thanks again Professor Samar for his presentation, and we learned a lot of things. We manage LSD are more better than previous. Thank you, Dr. Samad and Professor Mizan, for arranging this type of economic important diseases. Thank you again.
Well, you have asked a very good question about antiviral drug to be used in other diseases.
Methylene blue,
yeah,
like PPR or FMD diseases.
Okay. I had suggested acyclovir to be used in cases of parvovirus infection, as well as canine distemper, to some of the local vets in Mumbai, because when they read my blogs, this was the question they asked, that we have problem of distemper, and can we use this acyclovir. And then when I went for literature search, we could find few papers suggesting that acyclovir has been used in North American countries for viral disease like distemper in pet animals. They don't really treat large animals because they have a very good option of sending the animal to slaughter. So usually you will not find these cases where they have used such kind of drugs. But theoretically, I would say that any virus which is sensitive to acyclovir should be used. The only problem from theoretical part I face, and I have discussion with lot of pharmaceutic as well as nanotechnology group here in India, that we would like acyclovir to be targeted inside the cell. So we wanted to develop a kind of strategy where in case of dermal infection, I should be able to use a nanoparticulate acyclovir or methylene blue, which I should be able to deliver right inside the cell, because that kind of technology which we have for thalidiasis, anaplasmosis, tuberculosis, paratuberculosis, that is the patent which I have got on delivering drug into macrophage, by using solid lipid nanoparticle. So based on that experience, we are working with number of research groups here. As I have earlier said, that we have got a nanomethylene blue now, which is 50 to 100 nanometer size, and that would also be able to invade intracellular. So that should also take care of infection of the hidden viruses which are there in the dermal tissue. So lot of stimulus we have given to the medical scientists here to solve these kinds of problems. So let's hope that even for other diseases, we should be able to come out. And during the outbreak, we exhausted the entire acyclovir stock which was meant for human, and then the pharma industry got interested as to where it is being used, why it is being used, and now number of pharmaceutical industries are getting ready to market veterinary label acyclovir.
In case of methylene blue,
Yeah, same methylene blue. We are developing a nanomethylene blue for long circulation. Otherwise, as I have said, the problem with methylene blue is its very short life, because it is heavily charged molecule. So within 15 minutes, it will appear in urine, and by 1.5 hours, it is totally excreted, from the blood circulation. Number two, because it is highly charged, it is not able to get inside the cell. So it will not take care of any infection which is inside the cell. And the multiplication of the virus is such that it will enter into the nucleus. It will integrate itself into the the mammalian replication metabolism, replicate, and then come out of the cell. So you'll have to take care of both the virus which is circulating in blood, as well as viruses which are multiplying inside the cell. And the load of virus which is multiplying inside the cell is much higher than it is circulating in the blood, because once it is circulating in the blood, it is bound to platelet. And if there is high level of viruses bound to platelet, you have thrombocytopenia. So it ultimately have different kinds of complications. So lot of areas we are thinking of expanding. And as you have rightly pointed out, the laboratory facilities, same is the case here. But then we said, everywhere, there is a human pathology lab. Even in small block level also, there are human pathology lab. So we told them, Baba, your CRP is our CRP also. Your dimer is also our dimer. So there is no difference. We have to use same test. So they are very ready to agree, because it also expands their laboratory activities. So it becomes one health kind of activity, where one common resource in one block would be able to cater to both. So we should, I think, this is something which we should take care of, instead of, having laboratory at every place, which becomes economically not feasible. At least to some extent, we should make use of the pathology lab for common tests, that can be done.
Okay, sir. Thank you.
Okay, thank you.
You can take comments from Ridwan now, then finally can go to Faisal. Hello, Shubha.
Yes, sir, I can hear you. So, may I request Dr. Ridwan Pasha about any specific questions about that is not raised yet, or if you have any queries? You are muted. Would you please unmute yourself and start your question? Thank you.
Am I audible? Can you hear me?
Yeah, we can hear you. Thank you.
Okay, sir. Thank you. Thank you so much, sir, for your fantastic presentation. Especially, I have learned a lot from this presentation, because I had a big query about the brisket edema thing and the heparin and torsemide. Especially, I have learned a lot of things. We can do the CRP. I think we have the lab facility in our lab, but we can't do the D dimer yet because we don't do this. what I have, and I want to second it about the acyclovir, because I have started treating with acyclovir in the lumpy skin disease cases from 2021, when it was outbreak in Chittagong first in Bangladesh. And we actually, what I would like to say, looted the human pharmacy because we have finished the whole stock. But the problem is, the difference between India and Bangladesh is that the pharmaceutical industry or pharmaceutical companies in Bangladesh is not so much pragmatic like you. The veterinary industries are not so much pragmatic like you. So still we have to use the human acyclovir. Whenever I see, I want to share just what I've been seeing, the difference between maybe India and Bangladesh is I have treated a few firms for a couple of months in Chittagong, and I have seen that if we can diagnose early, because we only with the clinical sign, not with the laboratory findings. So with the clinical sign, if you can see, then I just only treat. I start only one thing, that is 𝐾𝐤𝐬𝐽 extract, Endographis paniculata. So I have seen that it is working fantastically. And a farmer, a few days ago, I went to a farm for different case, and he was saying that I treated some cow with your treatment, and I have treated some cows with vigorous antibiotic treatment. So I have seen that the cows which were treated with Endographis paniculata, they had a very good recovery. Only 1 to 2 lumps are there, and it was finished after that. And another thing I have got from a very old paper. I have read that paper maybe 1.5 years ago. Very old paper, maybe from 1970 or 75 it was published. I have seen that if we use povidone iodine on the lumps externally, then the lumps won't burst and the lumps will act good. And another paper I have seen about the acyclovir in the pox, regarding the pox, and I have used that. There is a acyclovir ointment is available in Bangladesh. So if someone will use lumps, acyclovir ointment on the lumps or the macule pustule, what is the typical sign of the pox, then it will not grow further. So I have used that thing also in 2020, 2021 that time. But this year I have been using only mostly 𝐾𝐤𝐬𝐽 extract. But if I see what you said about the calves, I start acyclovir then and there. So that is a thing what I have seen. And another thing I have seen that I maybe it is different from another point from India and Bangladesh is the Deshi cattles. That means the indigenous cattles, and especially the Shahiwals, are getting much more infected in Bangladesh, whereas the crossbreds are less infected. Even in a same farm as in Bangladesh we the dairy and beef farms actually in the same structure. Within the same structure we reared those. I have seen that the beef cattles much more susceptible than the dairy cattles. So the dairy lots are actually Holstein Friesian cross, whereas the beef stocks are generally Shahiwal or Sindhi, or mostly the indigenous cattle, because the red skins are much more preferable for slaughter. So I've seen this trend in Bangladesh. So I think we need some research. Dr. Mizan sir, Dr. Farhad sir, Dr. Okon sir was here. I think they can do some research, and we can also do some research. There's a thing, and thank you again. Fantastic presentation, sir. I have learned a lot. Thank you.
About methylene blue, I should add about methylene blue. There are three, different categories of methylene blue available in the market. One is chemical grade, another one is dye grade, and third is pharmaceutical grade. US pharmacopoeia, USP, or British pharmacopoeia grade. So whenever you want to use in lumpy skin disease, use pharmacopoeia grade methylene blue, and not the dye grade or the chemical grade. That is one thing which you should keep in mind.
Thank you, sir. Thank you, Dr. Pasha, for your important information, sharing nice, interesting information. And then I will request Dr. Faisal Talukdar, sir, and share some specific questions. and then we'll go to Dr. Nizam's.
Yeah, thank you very much for giving me the opportunity in this webinar. First, I give all the participants, those who are in watching this webinar also. So I'm Dr. Faisal Darda. I'm working in the epidemiology unit in DLS, and first LSD we um, outbreak investigation in Chittagong. It was done in 2019, and epidemiology unit with the help of 𝐓𝐢𝐬, we can identify the diseases in Bangladesh. And after that, we have done some activities regarding. We have done some clinical management guideline, vaccination strategy, and also we have done some piloting in three upajelas. There are 70,000 cattle we have given goat pox vaccine, which was collected from the Jordan, especially called lumpy sheet, goat pox stain, and we have given the vaccine in 70,000 cattle, and we have surveillance in 12 months, but we do not get any cattle affected or lumpy skin disease after vaccination. And also from epidemiology unit, I have completed 7 or 8 outbreak investigation in different district in Bangladesh. But recently, what I have seen, the young, especially those who are the less than 2 years old cattle, they are mostly affected. But those who are more than 2,000, we have not found any infected cattle. And also, the virulency is more than the previous time when it was introduced in Bangladesh in 2019. In that time, there may be the morbidity is more, but mortality is very less. But now in this now mortality in the calf, we heard a little more than the previous time. And also we give we have given a clinical management guideline that in all in all upajelas and all districts in Bangladesh, to how they manage the lumpy skin disease disease in their territory or in those areas. But today I have learned that you have give a new dimension, especially in the viral antiviral drug cyclovir. It was not included in our guideline, but we need to develop this guideline after if any published research, then we can include this one. But today I am little bit confused about that. We I have in one training program, especially 𝐒𝐢𝐿SD, but which I have seen that there is LSD is not a genetic disease. But in your presentation today, I have seen that LSD infected the cattle, and previously found in one journal article where they are in only Egypt. They only told that they have the LSD is a genetic. But today you also said that LSD is a genetic. So my one first question is that can we consider this is a genetic disease LSD, but LSD is a genetic disease or not? One thing. Another thing is in one part you have said that you have written either no NSAID, but another one you have said the NSAID. So you can just clarify this one, that if we use this NSAID or not. And third one is in our country, less than calves, less than 2,000 2 years old cattle, are mainly affected now in our country. So, what you think about this? That the more than 2 years age, they are not affected, but less than 2 years age cattle are affected. Especially those are calves, 1 to 6 months, they are mostly affected. So, what is your interpretation like this? So, this is from my side. Thank you.
Yeah, I think very interesting and pertinent observation, Dr. Talukdar. uh, you know, you have raised, one problem is that, you are having now, young calves, are at higher risk. That is because they have not been exposed, or they have not been vaccinated earlier. Now, out of my experience from foot and mouth disease, I can tell you that, taking care of such uh, infections in case of cough is extremely easy to do. See, in Maharashtra, what we used to have, even after doing foot and mouth vaccination, we used to get, young calves affected with foot and mouth, and then they used to die because of, myocardial, pathologies. Uh, so what we did, we found out that the colostrum, which was collected from the cows, in the population, was not having enough antibodies against foot and mouth disease. And that antibodies are not passed, in utero in case of ruminant. It passes through colostrum. So if colostrum is not rich in antibodies against a specific disease for a very long period of time, the calf, will remain exposed at high risk of the infection. Started, giving vaccination of pregnant cows, and then I found out that somehow there is a myth amongst vet that pregnant cows are not to be vaccinated, which is absolutely wrong. I would say pregnant animals are to be actively vaccinated for simple reason that if you are doing vaccination in third stage of pregnancy, the colostrum will be having very high level of antibodies and your calf will be protected. So then I started, following same, I started, doing vaccination thrice against FMD, in the last, stage of the pregnancy. And then I found that colostrum was extremely rich, and then we could control the problem. You see, the fear that, vaccination will cause abortion, might be true in case of human, where there is only one layer. Whereas in case of ruminant, if you see the placenta, there are three layers. And there are very scarce reports that the smallest virus known, that is bovine viral diarrhea, that is the only virus, which people have shown to pass through maternal circulation to fetal circulation in ruminant. Otherwise, nothing passes. So that once the calf is born, it is absolutely sterile as far as the antibodies are concerned. So that is where the problem lies. So if you really want to, control young calves, from the disease, then you'll have to think of, doing vaccination even in the pregnant animals. You look at, even in pregnant women, there are vaccination protocol, and that vaccination protocol is not only to protect the woman but also to protect the young child, which is going to be born, because there are going to be exchange of antibodies, from mother to fetus side. There was one experiment, which we did, wherein we use colostrum as a carrier of the vaccine, because that when during the first 48 hours or 24 hours, the gastrointestinal tract is open, is leaky, because there are specific receptors which can take intact protein inside, which closes after that. So cholesterol antibodies will pass through only for a certain period of time. So we said, why not even give antigen at that point of time, so that antigen will also enter. And since the calf, when it is born, is immunologically quite potent, it can produce antibodies, so it will bound. So there are a lot of such papers, which are published, where you can take help of vaccinating mothers to protect fetus, or calf after birth. So I would strongly urge that in some institute, you can take up this particular problem of vaccinating advanced pregnant animals, looking at the colostrum for antibody level against lumpy skin disease virus, and then check how much of the antibodies has been absorbed from the circulation. So I think those LSD antibody kits are now available, so you can use those. So this is a simple experiment which you can do, and you can solve the problem of problem in case of calves. And what was your another question?
So one thing is LSD. We can now from now we can consider LSD is a genetic disease. Yes or no?
I would say no. I would say no, because whatever reports are available, that suggests that there is a synergy between LSD and herpes virus, and combination of that leads to certain lesions. And what the papers have done is they have been able to isolate both the LSD virus as well as herpes virus, but we do not know whether it is the herpes virus which has caused the lesions or which is the LSD virus which has caused the infection. Therefore, till there is a very robust association is proved between the LSD virus and the disease in human, I think we should wait and not create a scare, but keep an eye and tell the vets that whenever they are handling lumpy skin disease cases, they should wear gloves. They should be very careful. And they should wear mask in case they are handling the lumpy skin disease with dermal infections, because the crust which is very rich in viruses would also have effect. And as I've said, there are 4 or 5 cases of herpes reported in our volunteers who were working in the outbreak. So we have to keep an eye on it, but not to create a scare and stamp that it is of zoonotic importance.
So my last my question or observation, that in your presentation you showed that in your first or second or third slide that no NSAID is administered, or in the last slide you showed that NSAID may be included in this in the
No,
treatment.
even there also
So,
I have said no NSID, but you can use prednisolone or dexamethasone. And if you are using prednisolone and dexamethasone, do not use NSID along with it. I have said to all our people that do not use NSID in case of lumpy skin disease. That is also a lesson which is from human cases which the doctors have treated, and they have also said no to NSID for simple reason that NSID is also nephrotoxic. It may cause problems with kidneys. So at that point of time, not to use. And then another issue with NSID is it interferes with immunological response, and we don't want to interfere in immunological response at any stage of the disease. So I personally don't encourage people to use NSID.
so,
I'll
so my
check
last question, not question, my observation is in our country we suggest some vets to use the ivermectin. Are you use this medicine for the LSD or something?
See, there were in COVID-19 at some stage, there was a mention that even WHO also had a controlled study to find out if ivermectin is antiviral, and finally they have come out with an advisory that ivermectin is not antiviral and it's of no use to use ivermectin. So I don't use it. So when specific antivirals are available, why to go for something which is non-specific?
Yeah. Okay, thank you.
So you can close now, I think.
Thank you very much, sir, for I think it's a very fruitful discussion, especially for veterinarians and also enthusiastic veterinary students. They will find it very interesting, and there was a lot of informative discussion. Also, Dr. Samad sir showed some practical examples how this is happening and everything. I think, and we also found some logical information from Dr. Ridwan Pasha sir, and also some treatment protocols comparing the feasibility in Bangladesh, and also conclusion from Samad sir on talk by Farhad Hossain sir, and then also Faisal Talukdar sir, he also mentioned some aspects from Bangladesh. So in general, I think it was a very fruitful discussion, and thank you, sir, for agreeing to share the documentation about the lumpy skin disease treatment strategies you detailed today. So we can share the informations in our web page and also Facebook and other places. And so thank you very much for your valuable time, and I hope it will be very helpful for all the audiences and also veterinarians. Thank you very much.
It was a pleasure to be with you all.
Thank you.